Hi, everybody. I'm Dr. Paul Green, and I'm a member of the Public Education Committee for ADAA, which is the Anxiety and Depression Association of America. Welcome to our webinar titled A Roadmap for OCD Treatment Options, Outpatient, Intensive, and Residential. Our presenter today will be Dr. Nathaniel Van Kirk. These webinars are presented by the Anxiety and Depression Association of America, which is the leading nonprofit organization in the field of anxiety and depression. Our mission is to improve diagnosis and promote the prevention, treatment, and cure of anxiety, depression, and stress-related disorders through education, like this webinar, practice, and research. Please take advantage of the amazing resources on our website, adaa.org. One of the things you'll find there is a great list of treatment providers. Just click on Find a Therapist on the top of the homepage. You'll also find on our website a free peer-to-peer online support group. Find the link by scrolling down the homepage. If during or after this webinar you have a question, you can send an email to webinars@adaa.org and we will do our best to get an answer to you. And you can support ADAA by making a charitable donation on the website. Okay, so let's get started. I'm very happy to introduce our presenter. Dr. Van Kirk is a licensed clinical psychologist specializing in the treatment of severe anxiety disorders, obsessive compulsive disorder, and PTSD. Currently, Dr. Van Kirk serves as the Director of Inpatient Group Therapy for McLean Hospital at Harvard Medical School, as well as the Coordinator of Clinical Assessment at McLean Hospital's OCD Institute. So now, let me turn things over to Dr. Van Kirk, and I will stop sharing so he can tell us what he needs to tell us.
Thank you very much, Paul. Appreciate it. Thanks for having me today. I'm glad to be here to talk a little bit about the various options that are available for OCD treatment and the various levels of care that we actually have through kind of throughout the country and some of the caveats that kind of go with them. And then in addition, I hope to give just a few kind of tips and tricks and pointers for preparing for things like intensive treatment, OCD treatment in general, and some areas for resources as you kind of progress through this process. And so just to start, I wanted to kind of go a little bit over just some of the basics of OCD, just to make sure everybody's on the same page. And so when we're talking about OCD or obsessive compulsive disorder, we're really talking about a set of symptoms or a kind of diagnosis that's characterized by two main pieces. The first is the presence of obsessions. Now, obsessions, while typically thought of within their relationship to anxiety increases, we kind of define obsessions as unwanted and intrusive and recurrent thoughts, images. But I think it's also important to note that this also can include things like intrusive urges or intrusive, not just right sensations, where something just feels a little off. So not just discrete thoughts and images, but also these kind of intrusive experiences, if you will. And kind of the hallmark of obsessions, because they can really take almost any form, is that they're unwanted. An individual may try to keep them out of their mind, and they continue to kind of push their way in. They cause a lot of distress. And we typically talk, as I mentioned, about the increase in anxiety that comes with it. But in addition, we now know that obsessions can cause a lot of different distressing experiences, including things like feelings of disgust, feelings of incompleteness, especially with not just right experiences in that subtype of OCD. But it can also cause things that we might call obsessional guilt. And in this case, that can be a guilt over something that hasn't occurred yet, or guilt over having a thought itself. Now, because obsessions can kind of take any form, they can also tend to be triggered by almost anything in an individual's daily life. So when we think about the OCD cycle, we usually think about a situation or experience or thought that triggers one of these obsessions that leads to this increase in distress. And as a result of that, the individual might feel driven to complete a compulsion or a ritual. And with the hope that by doing this compulsion or ritual, they'll have a decrease in that distress. And again, compulsions and rituals can take almost any form. So it's important to think about how we define them. So when we're talking about compulsions or rituals, we're really talking about any, be it behavioral or mental act that's repetitive and is really kind of targeted at either preventing a feared consequence that's related to the obsession, so a feared outcome or feared catastrophic outcome that might be triggered, or is aimed at neutralizing the distress associated with that obsession. And kind of the hallmark of compulsions is that they're really utilized in a very kind of rigid and excessive manner. And they may start out as a behavior that might be functional, but then move up kind of a continuum to an extreme where they're no longer functional, and they're very kind of they're rigid, they're extensive in the way that they're implemented. The tricky part about compulsions, and that I always like to talk to people about when it comes to OCD, is that unfortunately there are times when the compulsions kind of work at reducing that distress. And when you get that compulsion just right, it does tend to lead to a kind of immediate, really significant decrease in distress. However, that decrease in distress actually reinforces this cycle. And essentially, as you can see here, it actually, as that anxiety decreases, it reinforces this idea that that obsession or that thought is actually something that needs to be feared or addressed or dealt with. And then subsequently increases the urge to ritualize the next time around. So what ends up happening is this cycle kind of builds on itself, and OCD grows and grows and intensifies, and it gets harder and harder to get that kind of completion feeling or just right feeling associated with the compulsions. So they tend to become more and more rigid, more and more extreme, more and more complex. And OCD through this process will really kind of slide in and take over all different elements of an individual's life, causing significant impairment in social, occupational, just daily care, happiness, distress in all elements of life. And so really OCD is a very insidious disorder, and it can take so many different forms. Sometimes that can make it a little hard to identify if you're not familiar with it. And for many people going through it, when OCD first starts, they really may be wondering what's happening and why, because they may not really have heard about the different subtypes of OCD or the different ways that it can present, and may not really feel comfortable and can feel a lot of stigma and shame about asking for help, especially when it comes to things like the dimension of intrusive thoughts, which tend to be kind of those unwanted intrusive thoughts that are generally considered taboo, sexual in nature, might be considered repugnant images or horrific images. They also might be influenced what we call scrupulosity, where it has to do with one's religion. And these times can be really hard for someone to reach out for help. And the reason that OCD can take so many forms is that really at its core, we think of OCD as a fear of uncertainty. So OCD is a little bit unique from many other kind of anxiety disorders in a subtle way. And this is that even if someone can kind of say that, all right, I'm 99.9% sure that this feared consequence isn't realistic or won't happen. In those instances, when it comes to OCD, the OCD kind of says, wait, so you're telling me there's a chance? And if there's a chance, I've definitely got to do something about it. You can't just let this thought be, because you're saying there's a 0.01% chance. Can you take that risk? And so at the core, no matter how OCD presents, this fear of uncertainty is always kind of the core of this OCD cycle. And I think that process is really important to understand when it comes to understanding OCD treatment. And while OCD is really insidious, the great news is we actually have very effective treatments. And we have well-researched treatments that we know can really reduce symptoms for individuals. But
Well, let me interrupt you for a moment with a
Sure.
question some people out there, I imagine, might be having, which is that I know a lot of people with OCD are quite aware of this kind of uncertainty that you're describing so well. But I know that some people would say, well, I don't know that I really have uncertainty. Does that mean I don't have OCD? What would you say to folks with that question?
I would say no, not necessarily. I think it is kind of a higher clinical picture. And sometimes that uncertainty can be masked in terms of obsessions may actually overlap, and typically do overlap, with something that's very valued by that person. And so especially early on, or when symptoms are just starting, they may not realize that it's about that uncertainty because the fear may feel really, really real. And so it may not feel like it's just about that 0.01% chance. But in the beginning, especially, that fear may feel actually quite probable. And that's one of the things we tend to talk about, is this idea that OCD kind of tricks us into thinking that these outcomes are more likely, as do many anxiety disorders. And so even if it doesn't feel like it's about uncertainty, one of the questions that I typically will ask people is, do you have both like these obsessions and these unwanted intrusive thoughts that really feel uncontrollable almost, and that they push their way in? And do you feel that urge to do something in a repetitive nature to the extent that it gets in the way of your day-to-day life and functioning, to try to deal with those thoughts? Because if you have both components, then it more likely is still OCD. And then the uncertainty usually kind of comes as you go through treatment and you start to understand OCD a little bit better. Then that it becomes a little bit easier to identify when you're like, all right, I get that this obsession is unlikely, yet I still can't shake this what if feeling. And so it can evolve as you go through treatment as well.
Great,
that's a great question. And so, when we think about kind of the gold standard treatment for OCD, we really talk about exposure and response prevention, or ERP. And this really is kind of the gold standard treatment. There are many other treatment kind of aspects that are built upon exposure and response prevention, and I'll talk a little bit about some of those. But I just wanted to start with this because this is the gold standard, and we really believe that this really should be kind of the core of any kind of treatment attempt when it comes to OCD, especially at higher severity levels, because as OCD evolves, it can actually take some of the clinical skills or the more general clinical skills and turn them into rituals themselves as you're learning how to do this. And so if we think about that OCD cycle that I just talked about, exposure response prevention really has two main parts. The first is these kind of purposeful and prolonged exposures to the triggers of the feared consequences, so the obsessions themselves. And this can take a lot of different forms. You work with a treatment provider, kind of come up with ways that we can trigger these obsessions and sit with that distress. And the goal of this is really to kind of break that conditioned response between having an obsession and a significant increase in distress or anxiety. And over time, the more that you engage in these exposures, the goal is to kind of learn that anxiety as an emotion isn't harmful. That as an emotion, it will fade over time on its own as well. And that the more that you confront a fear, just like maybe a fear of heights, if you're and then you spend time working on a ladder, over time, you become more and more comfortable in that situation. And we're kind of doing the same process here. And that's the first part, is the exposure process. And there are two models to this. I'm not going to get too much into it here, but I think it's an important recommendation when someone's thinking about treatment, is to really understand how this works. And the first is through that habituation process, where the more that you confront a fear in a prolonged manner, the more that anxiety will decrease over time. And then each time you confront that fear, the anxiety will be a little bit less. And it takes multiple kind of practice attempts of confronting that fear. But the other is what we call inhibitory learning, which is essentially developing these inhibitory associations, where in OCD, for example, it's essentially inhibiting that need to engage in the ritual to reduce the distress or fear, and learning that you can tolerate that distress. And you can still, even though that anxiety may be with you, you can still live a meaningful and value-driven life. And that ritualizing isn't the only option. And there's a lot of subtleties to both of those. So that's one of my recommendations when someone's starting treatment, is to work with someone who has a good understanding of ERP and the reasons why it works, and can really sit down and explain the intricacies of how it works for you, so you know how to map it onto your symptoms. But then there's also the second part of ERP, which is really the most important part, and that is the ritual prevention. And in this case, the goal is to practice resisting the urge to engage in compulsions or rituals, and face these obsessions without utilizing those rituals to reduce distress. And the reason why this is important is it essentially kind of breaks that association between the fact that compulsions are necessary to feel better, and learning that anxiety will come down on its own, and learning that you do have a choice about engaging in those rituals, and that the rituals aren't necessarily a requirement and really aren't functional in the long run. And so you're really trying to reduce the necessity of it. An important piece of this is that doing ERP without the ritual prevention, unfortunately, can actually strengthen the OCD symptoms, because it's essentially learning that, all right, every time that I face this fear, I have to ritualize to feel better. And so ritual prevention is really the key part of any empirically based treatment for OCD. And so this is kind of the gold standard currently. And a lot of times we'll also augment this with things like cognitive therapy tailored for OCD, acceptance and commitment therapy, maybe DBT skills, and utilize these all within the context of ERP to kind of tailor it to the person and their symptom presentation. And so just to talk a little bit about how we kind of translate this in actual practice. So for those of you that are considering going through treatment, what does it actually look like? And so with the exposure component, the goal really is to learn that anxiety is not permanent, that we are hardwired for anxiety to increase and decrease over time, that anxiety is honestly our way of protecting ourselves and survival. It's hardwired into us, and it isn't inherently dangerous. But also
So it's
through
a
that,
good thing to have this anxiety then, huh?
yeah, I'd say it's if you feel no anxiety in your life, that's also concerning for and sometimes in another direction. So I always tell people the goal isn't to get rid of it, but it's to utilize it for what it was designed for, to help you motivate, be creative, be aware of dangers, but not have false alarms going off. But without anxiety, we don't have motivation. Without anxiety, it lowers creativity and it lowers productivity. So anxiety is a really important part of just our everyday life. And I think it's changing that relationship to that anxiety that's really important. And part of that comes with the building confidence in your ability to face fears, which is honestly, whether you have OCD or not, I think is a great skill all of us can practice a little bit more, is how to face our fears head on and build confidence, our ability to be resilient. And so a couple practical notes is when you're doing exposures, they need to be repeated and prolonged. I think that's one of the challenges sometimes that comes up, especially like outpatient therapy, when someone's just starting doing their own self-directed exposures, is you might get into exposure and try to do it in like 20 or 30 minutes. But really, we recommend somewhere between an hour to 90 minutes, depending on the severity of symptoms, maybe even a little bit more. But it's important that it's prolonged to give that process time to take place and that it's not a one and done. It's important to repeat it on a daily basis to build. It's just like practice. You know, if you're kind of learning to dribble a basketball with your opposite hand, you don't practice it once and then go into a game and only play with your opposite hand. You have to practice it every day to get ready for the game. And this is kind of what ERP is like. The other piece is that you can do it both in real life and through imaginal scripts. And I did want to just kind of highlight one piece when it comes to contamination OCD. A really important part that sometimes gets missed is this idea of cross-contamination. So with OCD, when you have contamination, like for example, if my hand was contaminated, I may have the urge to actually isolate that hand. And I might be able to go about my day without washing my hands, but I may not touch anything with this hand. And really, when we're talking about contamination exposures or negative associations, if it's more like a fear of like spreading negative energy into the world, things like that, it's important to really take those contamination fears and cross-contaminate them to your whole body. So it'd be things like rubbing your hands together, up and down your shoulders, through your face, touching all the things in your room or your personal space. Essentially trying not to have like a uncontaminated and a contaminated world, but to live in the world as it is. Then on the flip side with ritual prevention, really we're talking about learning more effective ways to manage distress without these rituals. And while we know that forced blocking of rituals can reduce the effectiveness in the long run, it's really important to help individuals, and as you're going through treatment, to keep an eye out for like subtle rituals, mental rituals, ones that you may not notice, subtle avoidances that are used to just take the edge off, if you will, to reduce the distress.
Can you tell us a little bit about what you mean by forced blocking of rituals?
So this a lot of times will come up when, especially when working with families, is the idea, well, you know, if I just block them from doing the ritual, won't it go away? Or if I remove their ability to do it. And really what we mean with ritual prevention is actually helping someone build the confidence to choose to not ritualize. One of the challenges is I think when you forcibly block it, or if someone removes your ability to ritualize completely and you have no choice in it, what ends up happening is an individual kind of the OCD kind of morphs a little bit and will say, all right, so only in this situation when it isn't possible, or this person is here blocking it, can I resist this ritual? When I'm on my own, I still can't, and I still have to do it. And OCD is tricky because it'll also sometimes morph, and it may create new rituals on the fly to account for that. So really the most important part is the individual making the choice not to ritualize. And so that's kind of what we mean, is that, you know, there may be instances if the ritual is causing harm to an individual, that there may be a necessity to protect an individual, to protect their well-being and protect them if they have a dangerous ritual. But that really should be done in collaboration with their treatment team, you know, with the family and with the individual, so that everybody's on the same page. But the goal is ultimately to phase that out so the individual feels like I can make this choice, and I know I don't have to.
So if we have any parents out there watching who have, let's say, a child or a teen who washes their hands excessively and who might be tempted to say, you're not allowed in the bathroom unless I'm there to supervise, what would you advise them?
I would advise them to actually have a family meeting with their psychologist or treatment provider or therapist who's doing ERP, and actually come up with a plan together. because a lot of times, and it's a difficult position to be in as a parent, you're watching someone you love suffer, and you really want to do everything you can to help them. And it makes sense. And then at the same time, you're also, their parent, and it's a little bit harder sometimes to draw those lines and know where that line is, because you're not their therapist. You may not know all the ins and outs of what's happening. And so I really think it's important in those moments, if you're a parent, to make sure that you have family meetings with, with your child's therapist, that you're all in it together. And that if you see things that you're not sure how to respond to, such as like, should I just lock the bathroom? Or how do I reduce my accommodating? And that's an important one, is not necessarily helping them ritualize or kind of making it easier for them to ritualize, but not necessarily kind of making it impossible without talking to the therapist first about how to do it effectively. And so it's a tough balance to draw, but I recommend anytime that comes up, and if they have a question, make sure that they meet all together and come up with a plan in collaboration together, so everybody's on the same page. That's usually the most important part as you're reducing accommodation, to make sure it doesn't like come out of the blue.
Good advice.
And so, ultimately, all of this that we're talking about, the really great news is that OCD treatment, ERP, is highly effective. When we look across studies, what we call a meta-analysis, where it looks at the effect of multiple outpatient trials, we actually see a very large effect size of 1.41. For cognitive behavioral therapy, that is cognitive therapy mixed with exposure response prevention, we see a similar 1.39. And in the field of mental health, this is astronomical. This is
Can you tell people a little bit about what those numbers mean, the effect sizes?
Yeah, so the effect is essentially the magnitude of change from beginning the treatment to the end. How much change occurs, in a sense, is one way to think about it. And really, when we look at effect sizes, they're kind of graded based on how large they are. So 0.8 and above is considered a large effect size, and is usually what we're aiming for. Like, usually in research, we'll feel really great if we get that in mental health. 1.41 is huge, which is really—
This is a very effective treatment.
Definitely. And usually you're seeing about a 60% reduction in symptoms. And sometimes people will see that and be like, well, that's not a lot. But the way I always frame it is, if you're spending 9 hours a day washing your hands and then have a myriad of other rituals, getting a 60% reduction allows you to live a life that is important to you and gets a lot of your life back. And that's just in usually about a 12-week, kind of a 12-week study. And so recovery is an ongoing journey. And so that 60% is kind of also a starting point where someone will continue to progress from there. But I will say that we know OCD treatment is highly, highly effective. But I also don't want to give the message that it's easy, because it is an incredibly difficult treatment. We're essentially asking someone to face their worst fears over and over and over again, and to not do the few things that give you some sense of relief or safety. And so, for family members or friends, I really want that are out there and kind of trying to learn about how to help someone that they care about who's going through this. I think it's important to recognize what it is that we're really asking someone to do to go through treatment. And it's not easy, and it won't be quick. And I hope that everyone will kind of imagine what it would be like for them to face those worst fears every moment. But for those of you out there who are going through OCD treatment, remember that by doing this, it is highly effective. And you've learned a skill that if you can face the worst fears that your mind has to offer, there's very few things in life that you won't be able to face effectively. And so, I always like to give that message and put that out there, but also acknowledge that there's some challenges to OCD treatment. Sometimes when it comes to very high severity or complex symptom presentations, comorbidities, if someone has multiple diagnoses, such as like depression, in addition, that can complicate the treatment picture and make it a little bit harder. And then in some areas, there may be limited treatment response. It may feel so overwhelming, an individual feels like they just can't do it and needs more support and may drop out of outpatient therapy. Also, in many areas, there isn't a lot of treatment options for OCD or individuals who truly specialize in OCD. And so those can be challenges. And it's in those moments where a more intensive or residential level of treatments, these higher levels of care that we're going to talk about, can come into play. So I want to give a little bit of an overview of the different levels of care that are out there, because a lot of times we think about outpatient treatment, but many individuals aren't aware that there are a lot of different options out there for individuals with OCD. So the most common one we talk about is outpatient treatment. when it comes to exposure response prevention, that's usually one to two meetings a week for about 12 weeks. And then you kind of reevaluate how things are going and continue. And it's done on an outpatient basis and the important part of this is that there's also homework in a sense that's assigned, or exposure practices that have to happen on a daily basis throughout the week. That is usually self-directed, where the individual's doing it independently. From there, we actually have a little bit higher level of care, which is an intensive outpatient. And this is usually, and it varies a little bit, but usually 2 to 3 hours a day. It can be either all individual, so like prolonged sessions that are happening multiple times a week, or it can be a mix where it might be a group therapy mixed with individual therapy. And in this case, it's usually 2 to 3 hours a day, 3 to 5 days a week. From there, we have a little bit more intensive, where the day program, here you're anywhere from like 2 to 5 hours, depending on the program. A lot of times this will involve individual and group therapy. And it'll be a couple hours, but not necessarily like the full day, but a good chunk of it. And then we have what we call the partial hospital programs. So these partial hospital programs are essentially day programs, and they range usually from 4 to 6 hours a day. But what's a little bit different about these is they typically will be in a hospital or academic medical center style setting, where there is a nursing staff or medical staff on site as well. And so this can also be helpful if there's comorbid medical concerns or changes to medication and things like that. And so partial hospital is essentially just structurally very similar to a day program, but has medical staff involved as well, and maybe a little bit longer day. And it's usually 5 days a week. From there, there's a couple residential programs. And so residential treatment programs, such as the OCD Institute in McLean, where I work, there's a number of them. The International OCD Foundation has a list of them on their website as well. So Rogers Memorial is a great one. We have one in Boston, one in Houston for McLean. And so there's a number of them throughout the country now that are being developed. And residential programs typically are 7 days a week. They're voluntary programs. I think that's really important to know. Is that these residential treatment programs include, I'll walk through all the different pieces, but they include a multidisciplinary treatment team. They're usually probably 6 to 8 hours a day, depending. And they run 7 days a week, and the individual will typically kind of stay or live within the program for a while. Our average length of stay at the OCDI is about 6 weeks, and it varies based on the individual needs of the person. And then the question I get a lot, and Paul, you and I kind of talked a little bit about this, is, are there inpatient options? And the kind of biggest differentiator between residential and inpatient is the voluntary. It's kind of voluntary and locked units. So in residential, they are open units. They're not locked. The individual can come and go as they please, typically, especially in adult units. It's a little different in child units, especially working with young children. But for adults, the residential is voluntary. You can kind of come and go at any time. Also a little less supervision in that sense. In inpatient, typically they're a little bit shorter stay. You can enter an inpatient unit voluntarily, but you also kind of have to let people know before you want to leave. They also will do kind of have higher staffing, so more frequent checks. This can be very helpful, especially if someone's struggling with rituals that cause harm or self-harm when they get overwhelmed. There's going to be higher staffing to help people through those challenges and prepare them for something like residential or partial. Unfortunately, there really aren't any OCD specific inpatient units that I'm aware of for adults. There is one that has an OCD track for children in New York. And there are some inpatient units that are now starting to have OCD kind of tracks in a sense. But inpatient stays are usually very short, between 3 to 7 days. Some will go up to 14 depending, but much shorter than residential. And unfortunately, this is still one area where there's a big gap. There aren't many inpatient services for individuals with OCD. And then one of the more recent ones that's been developed due to COVID has been the virtual partial programs, which are kind of online virtual day/partial hospital programs that are run completely virtually, but are designed to mimic those kind of more intensive programs. And so those are kind of the overview, and there's a number of different ways to engage in it. And part of it is thinking about what are your needs and what level of care fits the best for each person. And I think that's a conversation that's really important to have with your outpatient treatment team as well. Because when you prepare for intensive residential treatment, there's some important considerations to hold in mind on what it is. And so one of the first things to think about is, when should a higher level of care be considered? So one of the things that comes up a lot is that when stepping away from day-to-day life will actually allow for greater focus on treatment. So in some instances, day-to-day life doesn't stop when you're doing treatment. And sometimes day-to-day life can really make it difficult to engage in the extent of treatment that might be necessary for an individual. So stepping away to a higher level of care, kind of removing themselves from their day-to-day life for a little bit to really be able to focus solely on treatment can be a great
So what
benefit.
would be a typical example of when that would be appropriate?
So I think if someone has maybe more severe symptoms and has to do very extended or prolonged exposures, but maybe they're at work for most of their day and they can't take like a leave of absence without necessarily going to like a medical program, or they want to take a leave of absence because maybe work is making it so they don't have the time to engage in ERP. Or if, for example, this may actually happen too if someone is working like variable shifts or night shifts, and then you get kind of the reverse sleep cycle and fatigue that can actually, and there's some data to suggest that reverse sleep cycles actually interfere with OCD treatment outcome. And so in those instances, it actually might be helpful to take a step away to be able to get onto a steady, regular schedule that isn't variable. So you have kind of like a good structure for engaging in treatment. Another might be if you just don't have a place where you live that's separate enough for you to engage in your exposures, where you can focus on them. That could be another instance. There is also some instances where OCD symptoms become so severe that someone may struggle to eat, drink, even shower, take care of themselves, go to the bathroom, take care of family members. So in those instances where it's really interfering with daily life tasks of taking care of yourself, that's a good indicator that a higher level of care might be really beneficial. The other one that can be a very huge challenge because of how difficult it is if someone's struggling to engage in self-directed or independent exposures on their own when the therapist or the treatment team isn't present. And this can be very common with OCD because it is so difficult to face those fears. And so if someone's really struggling to do the practice sessions in between their therapy sessions, something like a day program where there's a structure to help you do it, where there's what we call behavioral coaching, where individuals will help you through the exposures and help and they'll kind of taper off to build confidence, can be really helpful.
So it sounds like, Dr. Van Kirk, that you're suggesting that these are ways that people should go about making the decision about higher levels of care if their outpatient ERP therapy might not be sufficient for them to achieve the improvement they'd like. But what if there are people out there who are wondering whether they're really doing ERP or not, or whether their therapist is doing that kind of treatment with them the way that you're suggesting?
That's a great question, a great point. Actually, this goes to the next one, which is when there's a lack of local services or someone's unclear. And there are many places where, unfortunately, there are times where individuals say that they work with OCD and they treat OCD, but maybe haven't specialized in it. And they have in many cases, it's good intention. They just may not know the subtleties of it. And if you're engaging in, and you've been engaging in ERP on an outpatient basis for quite a while, especially if you've been doing it for kind of pretty routinely for a couple months and you're not seeing any changes, that might also be a time to think about an intensive program or a specialty program to make sure to really learn the subtleties of exposure response prevention and OCD treatment.
Well, let me ask a follow-up question to that. There may be some people out there who are saying, well, I think my therapist is quite good at doing ERP, but I'm just having such a hard time getting started with these exposures. They're so hard. Yeah. Should I consider residential treatment or a higher level of care?
Definitely. I think that's a great time too. If you're feeling like the exposures are just so overwhelming that it's really hard to get started with them or stay in them sometimes, or if you get really overwhelmed in the midst of them and are having a hard time resisting the rituals, be it with your therapist or independently, that's a great time to think about a higher level of care where you can have a little bit more support as you're going through those exposures to kind of get started. And there is one other time that can be important, like one, if you don't have any treatment available around you. I don't want to kind of send the message that intensive treatment is only for those who have done treatment and failed, because there are instances where someone just doesn't have services around them. And that could be a really great time to kind of maximize those gains. Or if someone is, for example, on a break from work or a medical leave or on break from school, those can be great times to also utilize intensive programs to maximize your gains in those short windows to be able to get back to daily life following that break. And so those are all instances where I think a conversation with your outpatient team, if you have one, would be really important to think about if intensive level of care and which level of care might be most necessary. I'd say if you're really struggling with self-care and daily care activities, you might want to think about it like a residential level where you have 24/7 support. Or if the rituals take place like specifically during the evenings or really early mornings or times that you usually aren't meeting in a day program, that's what kind of residential programs would be the most benefit. So as we kind of wrap up some of this piece, there are a couple of misconceptions about intensive and residential treatment that I think are common when we talk to people who are coming into treatment, and a lot of fears about going into residential treatment and what it's going to be like. And so I wanted to address those just a little bit. So some of the common concerns that I hear a lot are, will I be forced to do exposures I don't feel ready for? And I think it's important to remember that all intensive treatments, especially day programs, partial, residential, they're all voluntary. And so we're not going to force anyone to do exposures. If they're not ready to do them, we may have the discussion about what they might need to do first, like maybe just develop distress tolerance skills or DBT skills to help them do those exposures that are more difficult. And we'll encourage people to do them, but we're not going to force you to do exposures. Ultimately, it is the individual's choice. Because that's really what we're trying to help people develop and learn, is that ability to choose for themselves. The other question we get is, what if I experience a higher level of anxiety beyond what I can tolerate? And I think sometimes that will happen in terms of like an unexpected exposure, or maybe someone's just starting out with exposure and the anxiety is more intense than they anticipated. The great thing about intensive programs is that they are kind of designed to provide support through those moments, and to remember that anxiety isn't harmful. Even if you have a panic attack, your sympathetic nervous system activation is hardwired into our body. And I always talk about this if someone's having a panic attack. Sympathetic nervous system activation was designed for us to survive. And it wouldn't work really well if we had a panic attack and then lost control of ourselves, especially if we're thinking about surviving like in the woods, right? Like if you see a bear and you have a panic attack, and then all of a sudden you just run around in front of the bear for a circle a while, then fall over. Really, you just gave a dinner and a show. Like our sympathetic system is really designed to keep us safe, and it's a protective system. And so I think that's also important, is that our body is designed to tolerate that anxiety. And while it's uncomfortable, it's not inherently harmful. And the staff will be there to help support you through it should that happen. But that's also why we use a gradual approach to help build confidence to it. Some of the others, and that's what coaching is like. Really, it's supportive and collaborative by nature. One other thing that comes up is this idea that if I go to intensive or residential treatment, that it's my last resort and I'll have no other options after that. I really think this is a really important one to kind of challenge and to hear from us, is that as an intensive program, and I don't want to speak for all my colleagues, but I feel like we've all talked about this a lot, is that our goal is to be there whenever you need us. Like if you need intensive support, if you're struggling, that's what we're here for. It's not the end of the road. It's just a step in the recovery process. And, we've had many people who have come back to intensive treatment when they need for like a booster or a tune-up, or their symptoms morphed or changed. And so it's not the last resort. Intensive is really designed to help you prepare to get ready to do outpatient treatment and help teach you the skills quickly and effectively. And that kind of goes with this first misconception that it'll be a fix or the end of treatment, that I'll leave residential treatment or intensive treatment and I'll never have to think about OCD, or I'll never be anxious again. So I really think it's important to know that it's a step on the recovery road, and it's designed to teach the skills to allow you to access outpatient treatment, because ultimately the goal is to get you back to your day-to-day life. And Paul, as we were talking about earlier, right? We don't want to necessarily get rid of all anxiety. We just want to change our relationship to it a little bit. And so these are kind of some of the misconceptions that come up that I think can help alleviate a little bit of the fear about reaching out for help at a higher level.
So what would you say to people watching who might be thinking, well, this OCD has really been a thorn in my side, or worse, for a long time. Maybe I should just go to a residential program and just knock this out, get rid of it, and then I won't have to worry about it anymore.
I would say there's kind of two pieces to it. The first is, if you're interested in residential or intensive, reach out to one of the programs, see if it's a fit for you. And there's no reason not to try it. If you think your OCD's been around for a long time and you feel like the extra support will help you take that step, go for it. However, it won't be a fix to get rid of it. And one of the things that I always like to talk to people about is when you think about obsessions and intrusive thoughts, there's been a lot of studies over the years that show that everyone has intrusive thoughts. And there's a great study that was done years ago that I always like to talk to people about, is that they essentially got a list of intrusive thoughts from individuals with an OCD diagnosis and a list of intrusive thoughts from a group of individuals and college students who had no mental health diagnosis. Mixed them up, put them together, and gave them to OCD specialists and asked, all right, can you tell me who has OCD and who doesn't? We really didn't do better than chance, because the content of the intrusive thoughts aren't any different. It's more the relationship to them. And so I use that as a way to say that it isn't a fix in that it's going to eliminate OCD. What it will give you is the skills and the knowledge on how to cope with it effectively, to where you can work towards the point in your life where it doesn't interfere anymore, and it can help you get back to your life. Does that help, Paul? You feel like, did that answer the question a little bit?
Yes, absolutely. It's very helpful. I'm wondering also about people out there who might be wondering, well, especially people that have maybe less of the kind of contamination themed OCD that we were discussing earlier, that really is a lot to do with compulsions of cleaning and et cetera, and concerns about contamination. But what about people who have obsessive thoughts about something they may have done or something about themselves that they're really concerned about, terrified of even? They might be out there thinking, watching this presentation, thinking, well, I could do one of these programs, but I'm still going to have this question. Like, I still might be either a horrible person, or I may have done something horrible in the past. I might be likely to do something horrible. I don't see how this is going to bring me any kind of clarity. So what would you say to folks like that?
I would say that, it's going back to what is the ultimate goal of exposure. And it's not necessarily to get clarity or get an answer, but it's to tolerate the uncertainty and learn to trust yourself again. And I think that's actually a core element of ERP and OC treatment in general, is learning to trust yourself again. And especially if thinking about those intrusive thoughts of harm, or intrusive thoughts of what if I'm a serial killer, or what if I hit someone with my car and don't remember? What if I burnt someone's house down by accident by not checking the stove enough, or what if I did it on purpose? And what if having this thought means I'm a terrible person? Part of what I'll say is that's actually a very common OCD theme. And part of what we work on is realizing that having a thought is not the same as doing an action. And it's okay. We all have thoughts, that at times we're like, oh, that was an intense one. But we kind of trust ourselves that our behavior will align with what we want to do. And what OCD does is take away that trust and say, well, if you had the thought, how do you know it won't? And that's really where that desire for clarity might come in. And so treatment is not necessarily about getting clarity, but learning to trust yourself again and acknowledge that there's always uncertainty there, but it doesn't have to dictate our behavior. We still get to choose. And so we can sit with that uncertainty and still live our life with that uncertainty.
I see. Okay, that's helpful. It makes a lot of sense. So it might not be that people should look for that kind of clarity or definitive answer that feels so tempting right now, but the ERP, regardless of whether it's outpatient or residential or IOP or what have you, involves a different approach to answering those kinds of questions.
Yeah, it's essentially learning that, all right, I have my general answer. I believe in who I am, and I trust myself that this is who I'm going to be. But I also know that I can't get 100% certainty, because there's really nothing in life that is certain. But the other thing that I always tell people I think is really important is that as humans, we tolerate uncertainty in our day-to-day life so frequently that we don't even realize it. Whether we walk outside and it's overcast, there's no guarantee that we won't get struck by lightning. It's not highly probable, but it happens. When we get in a car, every time we get in a car, if you don't have hit and run fears or fears around driving, there's uncertainty on whether or not we'll survive that car trip or we'll get in a car accident. But we essentially accept that uncertainty because we have to function. And that's even true with OCD, that usually it latches onto specific pieces where uncertainty isn't okay. But it doesn't it's hard to give yourself credit for all the other areas in your life where you've accepted uncertainty already and are living your life anyway. And we're essentially taking that same principle and trying to help people apply it to where their OCD is latched on.
Well, that sounds encouraging for people to think that they're basically taking a skill they already have and just applying it in a different context.
Definitely. Well, I'd say that kind of goes with that setting the stage for treatment, right? And I'm really glad you asked that question, because it does come up with this idea of one of the most important things for setting the stage for intensive treatment is actually, if it's available, finding an outpatient treatment provider that understands ERP, specializes in it, and can really give you a good, and to learn for each individual to learn how does ERP work? What maintains OCD? What is treatment? Both like the habituation model, the inhibitory learning model. But that's important because it allows you to set realistic goals. Like, all right, I'm going into treatment to do this. Not necessarily to get rid of my OCD or get rid of any anxiety, but to learn to tolerate and to cope effectively and to get back to living my life. Another thing that can be helpful is practicing distress tolerance skills and emotion regulation skills ahead of time so that when you go into intensive treatment, like, are these the coping skills that work for me and when? So that you have them should it feel overwhelming. And then your treatment team in the residential program can actually help you kind of learn when to use them, when not to use them, how to use them effectively. And then anything you can do to kind of maintain structure. Structure and a good sleep schedule are really important parts too of recovery, just in general. And so this is one that comes up a lot, is that preparing for intensive residential treatment, sometimes it can really feel, there can be a big urge to want to say, all right, I'm just going to pause outpatient treatment because it's not working and wait until I go to intensive or residential treatment. But what I think is really important is that pausing ERP and getting ready aren't necessarily equivalent. It's actually really important to continue practicing ERP, even if you're doing old ones that you've done before, just to keep the skills fresh and kind of build that confidence. Even if you're just repeating previous ones, continuing to engage in ERP as you kind of start looking for intensive options or maybe on a wait list is really, really important. And so just real quickly to wrap up, I want to give everybody a little bit of an idea of what the day might look like in intensive residential treatment. And it is based on intensive ERP. And I think that's really important, is there isn't necessarily any magic to intensive or residential treatment. It is exposure and response prevention, just like you would do an outpatient, just intensive. Usually it's about 4 hours a day of ERP. We just have a lot more support to help you navigate that on a daily basis. It includes individual therapy, and many programs also include family therapy to help family members understand how best to support their loved ones, how to reduce things like accommodation. And then there's also a lot of group therapy as well. One of the goals of the group therapy is really to help normalize the experience of OCD and to help people understand some of their, just different ways of navigating and coping with and overcoming OCD. So it can include things like cognitive therapy, motivation group, relapse prevention, mindfulness skills, skill group. There's also a lot of symptom-specific groups. So if someone's struggling with hoarding or has primarily symptoms that impact their bathroom usage or ADLs in the bathroom, or if they have health anxiety or scrupulosity, which is kind of OCD around religion or belief or faith or morality. If someone's struggling with perfectionism or tics or skin picking or hair pulling, a lot of intensive residential programs will have specific groups for those as well to augment kind of the ERP core to really tailor the experience to what you're struggling with. And then the other piece is medication management. And so I think it's important if you're also working with a psychiatrist to make sure that they understand ERP. And while I'm not a psychiatrist, I can't speak to the dosages, things like that. Generally speaking, the dosages for OCD are a little different than for other anxiety disorders. And it varies by medication, but it's important to know what the kind of effective treatment dose is for OCD because it's not the same as across the board. And so that's another thing that we'll tend to work on. And more recently, we've also included neurotherapeutics. So things like TMS has become a really great option for OCD. There's also
what does TMS stand for?
So transcranial magnetic stimulation. So essentially, it's not invasive. You kind of put on a helmet. It runs for about 15 minutes. You do it daily. A lot of people report maybe a little bit of like fatigue at times, or kind of like their head might itch a little bit. But it's usually used in conjunction with ERP, and it essentially helps kind of reduce the intensity of the anxiety and can reduce some of the symptoms, kind of turn the volume down, if you will, to allow people to access ERP skills a little bit more effectively.
That sounds good, but you're saying it's not a substitute for ERP.
Correct. It's very much like medication. It's an adjunct, if you want, for long-term recovery. But having ERP and behavioral therapy is really the core for long-term recovery. Also, some things that residential treatment can do, which is unique, is if you're struggling with comorbidities like really severe depression, or that what we call anhedonia, the lack of motivation, the difficulty in initiating behaviors. Many residential programs also can work with neurotherapeutic labs to do things like ECT if necessary, or TMS for depression. which can be effective in reducing those comorbid symptoms that might be getting in the way of treatment being effective. And so I think I've said, like, in summary, like 5 times, but I promise we're getting right towards the end. One big distinction that comes up a lot that I talk to people when they first come into residential treatment is the difference between doing ERP and engaging in ERP. Sometimes, ERP is so overwhelming that it's the idea of, when we're talking about doing ERP, sometimes we'll kind of go through the motions, but not necessarily connect to the anxiety. They'll try to avoid it or numb it out, or not really think about the obsession, but just go through the kind of functional behavior of the exposure. But a lot of times that can reduce the effectiveness of exposures. So when we talk about engaging in ERP, we're kind of talking about a willingness to experience anxiety and tolerate it, almost like welcoming the anxiety in and saying, like, all right, I'm going to do this. I'm going to fully engage with it. Whatever I feel, I'm going to allow myself to feel, and almost approaching with curiosity. And I'm going to let it kind of my experience ebb and flow and see what happens. So you're really trying not to get rid of the uncomfortable feelings, but allow yourself to sit with them. And then the other piece is that residential treatment and intensive treatment, really, just like ERP, is not a passive process. I encourage everyone that they should really be a core element of their own treatment team. It's a collaborative process. While as treatment providers, we know, like, OCD and the research and the treatment well, as an individual, you're the expert on your own life. And I think that's a really important thing to bring in, is help kind of working together and bringing your expertise of your own life, what's worked, what hasn't, to the expertise of the program to kind of tailor that experience to you.
So it's quite different, in terms of being an active part of your treatment team, and ERP being an active process. It's quite different than, let's say, taking penicillin for an infection, where you just have to take the pill and don't forget to take the pill, and that's about it.
Exactly.
It sounds like you're saying ERP is a different ballgame.
Definitely. It's a skill. It's more like skill building than anything. To go back to the basketball analogy, it's not sitting there watching basketball and then thinking, all right, cool, I'm going to go try out for my college team or the NBA. This is the practice, like the individual practice, the team practice. ERP is all about the experience of doing it and being engaged in it versus kind of watching it happen or hoping that it'll happen to you.
And do you find, in your experience working with folks in residential programs, that some people have a tough time really taking that engaged stance?
Yeah, it can be a real challenge. And a lot of times that's just, it's not that they don't want to, it's just that the emotions are so overwhelming and the fears are so terrifying that and in some cases, that's part of the OCD symptom presentation, where actually, like, taking control of and, like, acknowledging, all right, I'm an active participant, especially with intrusive thoughts, for example, can mean, like, well, if I'm purposely doing these exposures by my choice, not because someone told me to, does that mean that I'm a bad person, that I'm trying to be okay with this fear of maybe being a serial killer? Does that mean that I'm actually okay with it? I'm actually a bad person. But if someone else is telling me to, it's not my responsibility because they told me to. And so, like, sometimes OCD can play those subtle tricks, which is why kind of making the choice to be an active participant is so important, because it kind of keeps shuts the door on OCD from all the different avenues that it can try to stay alive, essentially. And this really goes to the motivation and willingness. I think as you're thinking about engaging in treatment, for anyone who's out there who's thinking about engaging, the question I like to ask is, what makes it worth it to take the risk and not ritualizing? And to acknowledge that we're asking you to take a risk. And one of the questions I like people to think about early on in treatment, and as you're preparing for residential, is what makes it worth it to you? What in your life is worth it to take that risk? And also to use that to kind of identify those very specific goals. What are the changes you want to make in your life? What are the functional changes? What are the things you want to work towards? Versus the goal of getting better is a common goal, and we all want to get better, but it's kind of like setting that goal of getting healthier. And the question is, like, well, how? What does that mean? What does healthier look like for you? And that varies person to person. Same with getting better. And so it can feel like you're always chasing like an end goal that keeps moving. And so setting those specific goals can really help with the motivation and help kind of bring that willingness to fully experience those thoughts. And we actually, Adam Reed and some of my colleagues at the Office of Clinical Assessment and Research had a paper in 2019 that actually found that individuals' ratings of their willingness to experience unpleasant and unwanted thoughts and emotions prior to ERP and their willingness to engage in the exposure again after it were predictive of better outcomes. So that willingness is actually incredibly important.
So the more willing people are to experience uncomfortable emotions, the better they'll do in ERP?
Mm-hmm. Yep.
Hmm.
And that's where the learning to tolerate, like emotion regulation skills or stress tolerance skills, can be really important. Like learning how to sit with uncomfortable emotions and negative emotions or unwanted feelings.
Well, it's something that nobody wants to do. So it must be, I'm sure it is challenging for a lot of people to come to the realization like this is something I have to try to get better at.
Definitely. In some ways, I always like to give the analogy of, it's kind of like a challenge to yourself, kind of like working out would be, right? It's like when you're lifting weights, for example, or if you're a sprinter, you're kind of challenging yourself to reduce your time, knowing that there's going to be some pain involved in it, but it's like a challenge to see how far I can go, how much can I handle, how far can I push myself. I think ERP is very similar, that no matter what I feel, I'm going to kind of challenge myself to go further, to get further into living my life. And the great news is intensive residential treatment works. So this is some data from McLean Hospital's OCD Institute, where we looked over a couple years of treatment for individuals with OCD. And on the left here, you can see the amount of change or symptom reduction in someone's Y-box score, which is kind of the gold standard for assessing overall severity of OCD symptoms. It's on a 0 to 40 scale. And we actually see a really significant drop from admission to discharge. And the docs here kind of actually refers to each individual domain of OCD symptoms. So contamination and washing, thoughts about harm or fears of harming others, being responsible for harm, docs 2, the intrusive, unwanted, taboo, sexual, religious thoughts. And then docs 4 is the not just right, perfectionism symptom subset. And across all of them, we see significant drops. And on the right here, we can see across from the first 8 weeks of treatment, you can see a really, when we look across everybody, we see a really great drop in OCD severity. Everybody's trajectory will look a little different. So this is an average. I think that's important, but there'll be ups and downs, peaks and valleys. Treatment looks a lot like the stock market. It just kind of like jumps all over the place, but it has a trajectory. And ultimately, this is kind of what that trajectory can look like from intensive and residential treatment. So the great news is it works. Even though it's really difficult, it can be very, very helpful.
Well, it sounds like that's an important message to people who might be thinking about residential treatment as just something to do because they're out of other ideas.
Mm-hmm. Definitely. And if I think that's a really good point, is that if for some reason things just aren't working, and maybe you're not even sure why they're not working, but you're engaging in ERP and something's not clicking, one of the perks of residential is that we get to know you so well. We get to see you so much because we work with you 7 days a week. There's staff with you 7 days a week. We can really almost kind of dive into, all right, what was getting in the way, and help you kind of overcome that barrier. So it can also be a great time that if you're doing ERP and it's just not working, and you and your treatment team aren't really sure why it's not working, that might be a great time for a higher level of care too, because we get a little bit more assessment going on as well to really figure out, all right, what was getting in the way? Maybe we can clarify some things. And so the final thought just on intensive and residential treatment is, I really want people to know that recovery is an ongoing journey, and intensive residential treatment is just one step in that journey. A lot of times we think of it as like a last resort or the final phase of treatment, but ultimately it's a stepping stone. And every time you have a setback or a challenge, it's another opportunity to learn how to adapt your skills to an unforeseen circumstance. And I think that's a really important thing to keep in mind as you're going through treatment, is that it's a process of essentially, and it's individualized. It's each person learning to live the life that they want to live amidst the challenges. And this is just one step to help you on that process. And so as we look at sorry, Paul, go ahead.
No, go ahead, please.
I was just going to say, if people have other questions, feel free, as Paul mentioned, to reach out with questions. Also, there's, I know on ADA's website, there's some really great resources and fact sheets about anxiety, OCD, treatment to find a therapist options. International OCD Foundation also has some great resources and a find a therapist, specifically for like residential programs or support groups. There's a list of their support groups for OCD as well, which I do recommend people get connected, just to normalize the experience and know you're not alone as you're going through it.
I did have one last question for you, which is that I'm sure, people out there who've looked into the possibility of doing something more intensive or even inpatient kind of treatment, and they may have done their own research and found places that seem like, spas, or have a lot of time spent in forests, and, a lot of massage, where you can go there for several weeks. But it sounds like you're saying that's quite a different animal than the programs that are specifically geared toward OCD.
Yes, I would say, you know, one of the ways that I did talk to people about like knowing how their OCD treatment's going is, if you feel uncomfortable and anxious, OCD is telling you you're on the right track to beat it. If you're feeling really relaxed during your treatment, my guess is you're probably not addressing the core fears. Since it's all about facing your fears, if you feel anxious, you're doing the right thing. You're facing it head on. And so I always say OCD is one of the few things that tells you how to beat it. Unfortunately, some of those programs that don't do ERP, you're not really, like, it might be relaxing. You might feel better after a week or two, because there is this thing we call the honeymoon phase sometimes, where when someone first comes into treatment, or when someone moves to like a new place or new house, their OCD hasn't connected with all the things in their environment yet. So they almost get like a little bit of some people will get a reprieve from their anxiety for a brief period until their OCD kind of like catches back up. For others, it may intensify because it's not their home environment. But there's usually this like 2-week period where it kind of goes one direction or the other. And sometimes that can masquerade as like things are going better. But if the severity goes down, I always say that's a great time to maximize your ERP. Utilize that kind of like little blip in there to like practice the skills and really get mastery of them, so that when it starts to latch onto your environment, you're ready for it. And you can kind of take the fight to your OCD. So yeah, I think that's it's important to be careful and make sure that they're doing exposure and response prevention, and that the place that you're going has an understanding of what it is and how it plays out. And if you're not feeling like anxious or like you're facing your fears, I would recommend looking for another place, or finding someone with expertise in OCD to help guide you.
That makes a lot of sense.
And then one thing that has come up that I always want to put out there is that there's actually been great, jumps in telehealth. And similar to everything I talked about, especially if you're in an area that doesn't have a lot of outpatient providers, look into telehealth. We do know that it's effective and that ERP can be delivered incredibly effectively through telehealth. There's also some online self-help programs like OCDchallenge.com, which is a self-guided ERP program that helps you kind of track your progress. There's some mobile apps like NOCD or NoCD and Live OCD Free that can be helpful in just tracking your progress and giving some education. So there are resources out there and great self-help books about exposure response prevention. So even if you're in an area that doesn't have a lot of providers, look into some of the telehealth options, because they're definitely growing very, very fast. And you can find some great resources and support there, even as a stepping stone. If your ultimate goal is to go to residential, use these as a stepping stone to get the process started. And so, with that, I'll stop screen share, but just want to say, Paul and ADAA, thank you so much for having me. And hopefully it was a little bit helpful in understanding the process of intensive residential treatment and how helpful it can be.
Oh, thank you so much, Dr. Van Kirk. This has been very helpful, and I think people can really use this as a resource to really know the difference between the different gradations of residential, inpatient, and intensive outpatient treatment. And so I wanted to thank you very much for that. And I wanted to thank everyone for watching our webinar and encourage people to like the video and share the video. And remember, if you do have questions, feel free to email them to us, and Dr. Van Kirk may be able to answer you depending on how quickly you send them in to webinars@adaa.org. So thank you all very much. Thank you, Dr. Van Kirk, and we'll see you next time.
Thank you.